Please unmute. Ma'am, please unmute.
Yeah.
Yes.
Is my screen visible?
Yes.
Yeah. So once again, good morning, my dear friends. I shall be speaking about the types of perimetry. Throughout my presentation, I shall be using the terms perimetry and visual field charting interchangeably, even though there is just a subtle difference between the two, which will become obvious to you as we go along with the presentation. Now, visual field, as you know, is that area, or rather that volume in space that you can see when you are fixing at a given object. Now, here I want to make a point. Most of the time in our clinics, we are checking the uniocular visual fields. But in our daily life or in our day-to-day life, we use both our eyes together. That is the binocular fields. Moreover, our binocular fields are increased by the movement of our eyes, that is the field of gaze. The movements of our neck and of our body increase the binocular field by adding on the field of view. So basically, our visual fields or what we see in our day-to-day life is a composite of all these features. So why do we persist in checking the uniocular visual fields? We do that because it is the simplest amount of information to process. Those of you who have learned how to interpret a single field printout would know that it is no simple amount of information. So now coming back to the types of visual field, I think a journey through the history of perimetry is important. Hippocrates was the first to describe a visual field defect, and that was a hemianopia. Ptolemy said that the visual fields are circular, while Da Vinci said that there is more on the lateral parts of the visual field. Marriott was the first to describe the blind spot. Now, this person is interesting. His favorite pastime was to optically behead a person by closing one eye and keeping the target's head on the blind spot. Thomas Young was the first to describe the margins of the visual field by a simple test that you and I do even now, and that is the confrontation test. So he found that the margins of the visual field extend 60 degrees superiorly, 60 degrees nasally, 75 degrees inferiorly, and 100 degrees temporally. So this charting of the margins of the visual field or the boundary of the visual field or the perimeter of the visual field is what is actually meant by perimetry. Von Graffe said that there are more important things happening inside the visual field, and that is why he introduced perimetry into the clinical practice. Bjerrum said that the central 30 degrees of the visual field is relatively flat. Actually, a visual field is hemispherical, and this flat central 30 degrees can be charted onto a black screen like this, which is called as the tangent screen. The process of charting it on the tangent screen is called as campimetry. Here, targets of various sizes like 5 millimeter, 3 millimeter, or 2 millimeter are kept at the end of black rods. The patient is seated 1 meter away from the screen, and these targets are moved from the periphery towards the center along each of these radial lines. Now, when you check perimetry by moving the target from the periphery towards the center, that is called as kinetic perimetry. And by now, it must have become obvious to you that kinetic perimetry is very labor intensive. It requires a lot of time. And also, it requires that the perimetrist be very skilled and efficient. Therefore, Professor Goldman and his team at Hagg Street decided to automate kinetic perimetry. But they soon found that it is very difficult to control the direction and the motion of the target, and therefore all the innovations in kinetic perimetry came to a standstill. Frank Fankhauser, who was a student of Professor Goldman, found that it was actually static perimetry which can be automated. Automation actually means to obtain quantitative data or data in the form of numbers about a given procedure and then to process it statistically. So Frank Fankhauser automated static perimetry and produced the first static perimeter, which was the Octopus 201. And therefore, he is rightfully known as the father of automated perimetry. Now, what is the static perimetry, or what is done in it? Here, the location of all the points on the retina are charted along the X and the Y axis. And then the light sensitivity of each of the points is charted along the Z axis. So this gives you a 3D graph. And the graph that is obtained is a hill of vision. So this hill of vision has the fovea at its peak, which has the maximum sensitivity, excuse me, and the periphery of the retina, which has the least sensitivity. So what is this retinal sensitivity? Retinal sensitivity is that minimum light intensity which a person is just able to see when a stimulus of increasing intensity is presented to a patient. And it is better described as the threshold. Now, you and I are all human beings, and what is recorded as my retinal sensitivity at a given point? Say you are recording 20 decibels at a given point now. If you check me later after say 2 hours, the point may show 22 decibels. If you check another person who is as healthy as me and as old as me, you might get about 18 decibels. So there is a fluctuation in the values of sensitivity at a given point. So when the definition of threshold was redefined, keeping this fluctuation into mind, it became that stimulus luminance which is seen 50% of the time. And then when it is charted on a graph, it gives you the frequency of seeing curve. And this frequency of seeing curve gives you a more working or operational definition of sensitivity. Now, charting the sensitivity at all the points of retina would be very, very time consuming. And so a sample of the representative points on the retina is given. And for a 24-2, these are the representative points which are sampled. And then there are 4 general categories of testing strategy, of testing the threshold. They include the supra-threshold testing, where you present a very bright stimulus, and then the patient says whether the patient has seen or not seen the stimulus. So it is like a screening test. Threshold related strategy, we do not use it much, but the current standard for automated perimetry is the determination of threshold, the threshold test. And a threshold, as we know, is basically that intensity of light which can be seen 50% of the time. Now, determining threshold, even at those points which we have sampled for a test, is itself very time consuming. So what is done? We do something called a standard staircase strategy. These staircases strategy are actually very complex, but I'll give you a simple up and down strategy where we increase the intensity of light in steps of 4 decibels. And when the threshold is crossed, we decrease it in steps of 2 decibels. And again, when the threshold is crossed, we increase in step of 1 decibel. But it was found that again, this strategy is very time consuming. This determination of threshold is very time consuming. And so Professor Anders Heil, a Swede, determined the Swedish interactive thresholding algorithm, which is actually a family of many tests. This includes the CETA standard, the CETA fast, the CETA faster, and the CETA C. At the same time, for the octopus perimeter, the tendency-oriented perimetry strategy is used. Now, these testing strategies are patented, so we don't have much information about them, but they adapt throughout the test in response to the patient's performance. There is another testing strategy called the GATE, German Adaptive Thresholding Estimation, which is as good as CETA. Now, CETA, or tendency-oriented perimetry, when it was compared with the threshold test, do not lose any accuracy, or very little accuracy is lost. And also, they are very efficient with respect to the time taken. A full threshold strategy requires about 12 to 15 minutes, while a CETA standard 30-2 needs only 12 minutes. A 24-2 CETA standard needs about 8 minutes, while a 24-2 CETA fast needs only 5 minutes. A 24-2 CETA faster needs only 3 minutes. So once you have measured the threshold at all the designated retinal points, then the software package in the machine takes over. That software package is StatPack, which compares these measured values with the normative values with respect to age that are stored in the computer to produce what is known as the comparisons to normal. These comparisons to normal are then displayed in the Humphrey printout as numerical values like this or as grayscale plots like this. These are the grayscale plots, and these grayscale plots also give the statistical significance. Now, the interpretation of a single field printout is it's a class in itself, and that will be taken some other time. In the octopus perimeter, it is shown as a color-coded map and also as a defect curve. So up till now, what we have learned is actually the standard white-on-white perimetry. So we know that glaucoma is a disease of the retinal ganglion cells. So if we plot the number of retinal ganglion cells along the vertical axis and the age of the patient or the time in the horizontal axis, we get what is known as the glaucoma concept diagram. So we are born with a certain number of ganglion cells and we lose it at the rate of about 1 ganglion cell every 90 minutes, such that by 50 years of age, we have lost about 250,000 ganglion cells. And that is the normal rate of loss, and that is shown by the slope of this green line. When glaucoma occurs, as is shown by this blue line, what happens is that it accelerates the process of the retinal ganglion cell loss, and visual acuity very rapidly drops down to these disability levels. That is the gray part. Now, certain amount of damage has to occur before the conventional white-on-white perimetry can diagnose glaucoma. So the patient is diagnosed somewhere here. And this amount of damage, usually when we detect the patient in our clinics, the patient has a moderate or an advanced glaucoma. Now, if we were to institute a perfect kind of treatment, which is very rarely available, then the rate of ganglion cell loss can be made equal to the normal loss. The slope of this line also matches this line. But we know that that happens only very rarely. Instead, we have a partially successful treatment protocol, which is most of the time. So person's progression is delayed, but still sooner or later in the lifetime, the person's visual disability falls in the visual disability range. Now, if we have some mechanism by which we can detect glaucoma earlier, somewhere here, such that even if we institute a partially successful treatment, the person's graph would be somewhat like this, which I have traced. So we would be delaying the glaucoma progression. And that is where the non-conventional perimetric techniques come about. So non-conventional perimetric techniques are basically meant to detect glaucoma earlier than the standard automated perimetry. And also, they are meant to overcome the patient-related errors. And let us just have a quick recap of the classification of perimetry. The perimetry, as we know, can be divided into two branches: the kinetic perimetry and the static perimetry. Kinetic perimetry, we know that proceeded to become automated, and most of the innovation stopped. Static perimetry, especially the automated static perimetry, divides itself into two branches. One is the conventional static perimetry, which we also know as the white-on-white perimetry. I have described about it. And the second is this branch, the non-conventional perimetry. So I shall be describing about the non-conventional perimetry. The first non-conventional perimetric technique to be described was the short wavelength automated perimetry, which is also known as SWAP. Before I describe SWAP, I want you to know about the retinal ganglion cells. The simplest way to classify the retinal ganglion cells is into three types. The first is the P type, which ends in the lateral geniculate nucleus as the parvocellular pathway. The second is the M type, which ends as the magnocellular pathway. And the third is the non-M or non-P type, which ends as the coniocellular pathway. So SWAP aims to test or stimulate the blue cones by stimulating the coniocellular pathway by producing a blue stimulus on a yellow background. Most of the Humphrey perimeters have this option of obtaining blue stimulus on the yellow background. Even though SWAP has increased or improved sensitivity as compared to the white-on-white, The problems are that it has higher test-retest variability, it takes more time for testing, and it is affected by cataract. You know, cataract does not allow blue light to pass through, and therefore the patient will find it difficult to see the blue stimulus, and therefore SWAP did not live up to the expectation of detecting perimetry early, glaucoma early. And so the next type of perimetry, the frequency doubling technology can be considered. The frequency doubling technology aims to stimulate the MY cells of the magnocellular pathway. Here, a frequency doubling illusion is created. The testing stimulus is a large one. This is a large testing stimulus, and about 17 to 18 points are tested. And the probability symbols are displayed on the printout. This test has high sensitivity and specificity and low test-retest variability, and lesser time is needed for testing. So you can remember it by using this mnemonic. Frequenting McDonald's seems crazy. Another test is the fundus-oriented perimetry, where a personalized perimetric grid is superimposed on the fundus image of the patient. This is available as Compass in the US. It gives you a good structure function correlation, but not available in India. Multifocal ERG and multifocal VEP are useful for those people who have divided attention span, because you are recording the patient's electrical response when a stimulus is presented. It is not of much clinical use. Another one which is in recent times it is more seen is the virtual reality perimeter. It is a supra-threshold device which is mounted on the head. It is portable and low cost and very convenient, but its sensitivity is less than the standard automated perimetry. And I want to point out that perimetry has still some problems. It has more of test-retest variability, and there are lots of unsolved issues, including lesser sensitivity. So artificial intelligence and deep learning techniques, especially the deep learning neural networks, can be used to identify glaucoma early. However, I want you to exercise caution, because this may create a lot of emotional or psychological problems, because a potentially normal person is potentially being given a blinding diagnosis. And also caution should be exercised, because too many people would be diagnosed with glaucoma, creating logistical problems. So this was about the types of perimetry. Thank you very much for your kind attention.